welcome to the Global Health Lecture Series. And Dr. Berman sends, his apologies for not being here and presenting. So I got, invested with the task of something that is actually a pleasure for me, a great honor, because I have known Ana Lucía Garcés Marcia del Valle, as we have the long name in Latin America since probably, I don't know if you were a high schooler or probably early in the medical school. And in fact, I have to say that after I graduated from medical school, my first part of my public health career was under the directives of Dr. Garcés, who is her father, one of our public health experts in Guatemala, that for many years we were trying to build the National Institutes of Health of Guatemala. So I do have a close relationship. And then she later, she came and sort of did some electives with us and other things. But she has had a remarkable career. She's one of the leading experts in public health and in academics in Guatemala. And I have to say that she has, not only worked with the Ministry of Health for several years, where she was implementing a lot of the initial cancer screening programs, but later went on to become under, the collaboration with Nancy Krebs and Michael Hambidge, a part of the Global Network for Maternal Child Health site in Guatemala. From them, they have spent the last 10 years really advancing the science and the evidence for, not only how to best care for pregnant women from a nutrition standpoint, to how to resuscitate babies, and many other protocols that the Global Network, I think, has put out there as part of a great NIH collaboration. So she's a senior foreign investigator for that network, and again, someone that really has given a great push to women and academics in Guatemala. So I think you are in for a treat. She's going to probably tell you a lot about how difficult, challenging, but also rewarding is to do research in Guatemala. So thank you.
Thank you. Thank you. I'm not sure if I'll be able to fulfill all that, but I'll try. And thank you so much for the Global Health Center for inviting me to present today. It's a great opportunity to me to be able to share what we've done. And thank you. I want to thank Dr. Nancy Krebs, the head of the section of nutrition, and Dr. Michael Hambidge, who aren't here, who we've worked with for the last 15 years. And my presence here is part of an ongoing collaboration and a very strong collaboration with them in Guatemala. So we hope to be able to share that with you today. And so the topic of my talk, the basic story that I would like to share with you is how and why to do research in Guatemala. And I know that there's a lot of research that goes on that's at different levels and that's probably considered very high levels, laboratory or very high level at other levels. My purpose is specifically for public health because I think I am a public health person at heart. So all of the research that we've done and the research that motivates me more personally is for the improvement of public health in Guatemala. And you can see how I cut my name down. I have problems with my passport and other stuff, but everywhere the two names that I chose are just Ana and Garcés. So the basic outline of my talk, I want to talk a little bit about the history of Guatemala and the context in the country. Also about doing research, because I think that in Guatemala, as well as in many other low and middle income countries, there are a lot of priorities that are not being met, which make it very difficult to focus on research. When you still have a lot of problems in being able to give healthcare and being able to get to the most underserved populations, it's really sort of a luxury to be able to do research. So I think that that's really important to keep in mind, because it also sort of explains why there's so many differences in that. It's not that we don't think it's important, and it's not that we don't want to do it. It's that there are a lot of other things that we have to think about. Then we want to share the experiences, the experiences that we've had in our collaboration, and I'm going to talk specifically about nutrition and maternal and infant health, and then a little bit moving forward. We, thankfully, were just approved for another 5 years of the global network, so we'll be able to continue up until 2023, so we would like to share some of that with you today. So because, as my father, the public health person who Edwin mentioned, always says that we're not anything more than the result of our history, that the conditions where we are right now, I just wanted to take a moment to go over the history of Guatemala as a country. So many of you probably have heard, or you might have seen the ruins and the pyramids and all that, and the Mayan civilization was in Guatemala, the southern part of Mexico, and Guatemala and a little bit of Honduras, from 2000 before Christ up to 1000 after death. There's a really good special on National Geographic if anybody's interested in that. They've now discovered that there are more than 60,000 different structures that had not been discovered previously. So it just goes back to how large the Mayan population was and the civilization as a whole. And this is interesting because it brings information that the population of the Maya at one point was believed to be 10 million at the highest time. So there was certainly a civilization long before the Spaniards got there, and a strong civilization. Then the Spaniards got there, and there was a Spanish colony between 1600 to 1821, which, you know, all the things all the way from the Spaniards, they sent the indigenous population, which lived on the lowlands, which were more fertile. They sent them to live to the highlands because they wanted to be able to keep those. And much of what we have today is an inheritance of that whole structure that happened during that time. Then in 1821, independence was signed. And this guy, his name is José Cecilio del Valle. The reason it's called independence is because it wasn't really the result of a strong social movement and that it made changes for the country. It was more a result of the oligarchy in Guatemala getting together with the Spaniards and then saying, okay, we basically have to transfer power, so we're going to have to transfer power. But it didn't really mean a democracy or improvement of living standards. It was more just signing that we'll do it and then everything will basically stay the same. So that's why we call it the independence. Then we had dictatorships, military dictatorships from 1821 all the way to 1945. So there were different people that stayed in power for as long as 20 or 30 years. And then in 1945, we had a democratic spring, which lasted, and we call it the spring because it was a lot of social movements and a lot of social improvements, including a social security system. The public university gained autonomy, and a lot of different changes and improvements. Women got the right to vote, happened during this time. So unfortunately, it only lasted 10 years because we had a strong group inside the country, and we also had intervention from other countries that were not in the interest of democracy continuing in Guatemala. So that ended in 1955. So we came upon military dictatorship again, which lasted from 1955 all the way to 1981. And this is when all the terrible massacres occurred, and we move into the Civil War from 1960 to 1996. So it's estimated that about 40,000, somewhere between 40,000 and 100,000 people were massacred or disappeared during this time. So if you see in the news now, what's been going on is that they've been going to these military camps, and then they've been uncovering and then finding all sorts of bones and remnants of what happened during that time. So when you see it, this is all that happened during this time. So if you think about it, this wasn't really that long ago. I mean, this is really recent history, and I know that as Guatemalans living in Guatemala, we still keep a lot of that today. So in politics today, in our country, you'll still see a lot of discussion related to this on both sides. And then sort of trying to get democracy across, somewhere in the middle between the discussion. So after the Civil War, we came into democratic governments in 1996, and we have had democratically elected governments since 1996 when the peace accords were signed. Well, no, we've had democratic governments since 1984, but the peace accords were signed in 1996, and then we've continued to have democratic governments since then. I would say that our governments haven't been of really good governments in the sense of being efficient at what they're doing, especially this one. This one has been really more, I would say, worse than others. We now have elections coming up in just a few months, so we hope to continue on the long road to democracy. Claudia was Guatemalan, but we have to continue maintaining hope and I mean, certainly that it can only get better. So this is where we're coming from. So thank you for listening to my history class. I just wanted to frame the discussion. So Guatemala is 108,000 square kilometers, which I looked it up today is equivalent to 41,000 square miles, which is the size of Maryland. We have a lot of different regions within the country. So we have mountainous highlands, which are somewhere around here. So our projects are here right at the beginning of the Western Highlands. This is where most of the population is. Then we have the Pacific South Coast, which is, I would say, better off socioeconomically. And then we also have Petén and Guatemala City, which is right here. So if you look at Guatemala, it's a lot of very different populations within a relatively small country. 60% of the population identifies as Ladino and 40% identifies as indigenous. But this gets a little bit more complicated because when we talk about indigenous population, it's actually 23 different ethnic groups. And each ethnic group speaks a different language and doesn't identify necessarily with the other ethnic group. So this adds to the complexity of the population in Guatemala. I looked it up recently, and then in Latin America, Guatemala has the largest proportion of indigenous population that was indigenous to the region before the Spaniards came. The next one is Peru, which has 20%. And then after that, even the surrounding countries, which are Honduras and El Salvador, have around 5%. So Guatemala is really unique in that regard. So you can imagine the language when you want to do an educational intervention, when you want to do any type of thing, you have to think about all this and adapt it. It makes it more complicated. Religion, 95% of Guatemalans identify with a religion. So I would say that religion is a very big part of daily life. Most are Catholic, about half or close to half are Protestant. And then there's also indigenous Mayan beliefs, which are not necessarily contradictory to the other two, but they're very much there. And then here, you can see how the structure of rural and indigenous has changed in the last few years. In 1981, rural was 70% of the population, and up to now we're exactly half. Half of the population is urban, half of the population is rural. So this has also had significant changes in health and education and other things. We're a population of 16.5 million. As you can see, 50% of the population is under 19, and we have very few under 65. Our fertility rate is the highest in Latin America, although it's gone down a lot. It's below 3 right now, but it's still the highest in Latin America. And if you look at different regions of the country, there are obviously big variations. In the capital city, it's under 2, while in some, the indigenous populations, it could still be at least as high as 4 or 5 children per woman. Life expectancy has increased, but it's interesting that the largest increase has been with women in comparison to men, quite a gap. And as you all know, there's a large migration to Mexico, US, and Canada. And our poverty rate right now is 59%, and the extreme poverty rate is 25%, which we're very much trying to change and trying to improve. And among all this news, which might be sort of a challenge, I think that a very positive and a good thing in Guatemala is that there are very strong social networks and there's a sense of community. And I think that that helps a lot in the population and is something that can also influence all aspects of living. And have you seen these happiness surveys that they evaluate where happiness lives? So Guatemala's in the top 20 countries in happiness among the world. So I think that that's also relevant because it's also part of life. I think the heading was something like a poor but happy country. So it is something, to take into account if you want to talk about quality of life as well. So these are our deaths by age and sex that occurred in Guatemala between 2013 and 2015. So it's interesting because you can see in women and then in men. So it's very interesting to see how many more there are in men than in women because one's on top of the other. So if you look at all these excess deaths that are happening in men, that's probably going to be a result of violence or accidents, which are much more common in men than in women. Guatemala used to be classified as one of the most dangerous countries in the world. Thankfully, in the last few years, it's improved and the mortality rate has gone down a lot. But this is obviously still a problem in comparison to other regions of the world that are much safer. But for example, Honduras, I think the mortality rate per 100,000 is like 60, and in Guatemala it's down to like 25. So there have been big improvements. When you look at the top causes of death, and this is death, not disease, you can see that it's interesting because we're definitely transitioning. So we have cardiovascular, respiratory diseases. Some of these are probably mixed infectious and chronic diseases, but I would say that a good proportion is chronic. Diabetes, then violence, tumors, cirrhosis of the liver, renal failure, and then you can see the ones that were probably a huge problem for us as causes of death that have gone down a lot. So diarrhea, nutritional causes, and infections. So as I said, one of the things that I would like to talk about today is nutritional status. And as you might have seen, Guatemala has a huge problem in stunting, and it's a problem that doesn't seem to be making great improvements. It's maintained pretty much the same. It had some improvements, but not a lot. So according to the 2015, 47% of children are stunted. This is a USAID, this comes from a USAID report that was just published a few weeks ago. So they compared the DHS survey in 2015 to the results in 2002. So you can see the same methodology over a good time period. This is how much it's reduced in ethnic groups, but in indigenous populations divided by ethnic groups. So it's interesting. I apologize because the font is too small, but this is in the Kekchi. The Kekchi have had an 18% reduction in infant stunting. And then Cachiquel have also had large reductions. And it's interesting because in the non-indigenous, which is the last bar, the reduction has been 6.4%. So it's been a lot smaller than in the indigenous. Of course, you would assume that the non-indigenous were taller to start off with. But obviously, we're seeing some big improvements in indigenous population. And then we also have, if you've traveled to Guatemala, you can see that it's interesting because we have this huge problem of stunting, but we also have overweight women. So it's very common to find both. In 19% of homes, there are stunted children and overweight mothers, which is part of what we're trying to figure out and see what can be done about it. So this is in different groups, so non-indigenous, indigenous, and then the different indigenous groups. But you can see that it's really a problem and something that we can't not pay attention to. So why is childhood stunting important? It's important, and this was a declaration from the World Bank Group, because as you probably know, it can affect illness, deaths, learning outcomes, poverty, and diminished productivity. Almost 160 million children are affected. And it's sort of a silent emergency, because for at least inside Guatemala, I'm sure that anybody can tell you that the general perception is that Guatemaltecos somos bajitos. So the Guatemalans we're just short. Mm-hmm. So that's like when you're in the country and you don't have access to a lot of people outside. That's just how we are. There's no reason to think otherwise. Mm-hmm. So, but the problem is very much there. It's sort of silent. So this is something that we want to explore further. This was taken, we had a student do this analysis in last year, but she took the DHS survey and she spread out and she separated stunting by age group and by ethnicity. And she also added on the survey that had been done in 2015 to all the previous DHS surveys. So that gave us a database of women that had been born between 1945 and 1995, and then they were all lined up one after the other. So what we found was that this is in non-indigenous women, and this is in indigenous women. So if you separate them by quintile, you can see the non-indigenous, the richest non-indigenous woman is here, and this is the poorest non-indigenous woman. So you can see that the poorest non-indigenous woman is still taller than the richest indigenous woman. So there definitely seems to be something there that we need to look at, because the economic position is not as strong as the ethnic group. So this was an interesting study in the sense that it allowed us to look at 50 years of growth in the Guatemala population. And it turns out that in these 50 years, the Guatemala population, on average, had grown between half a centimeter to a centimeter, while other populations can grow up to 5 centimeters. There's a little discussion about the methods, but they can grow at least 5 centimeters. And in Mexico and Colombia, our estimates are that they can grow up to 9 centimeters in that same time period. So this So this also contributes sort of to the discussion of what's happening and why is stunting such a big problem. And even though we have all these problems and all these issues, you could say on the whole that the economic situation has improved during this time period. So it just gives you more to think about. And we're trying to think with Nancy and figuring it out. So this obviously is going to impact the maternal health and the chronic diseases in all of these groups. So we can switch now for a minute to maternal and reproductive health. As I mentioned, we have the highest fertility rate in Latin America, 24.6 births times 1,000 women. The contraceptive prevalence rate is 60.6%. And here it's really relevant, the impact that religion has on women's access to contraceptives or not. There's a law, and we actually need to have a law in place to ensure that all women had access to contraceptives. So by law, any health center has to give contraception to women free of cost. However, Guatemala is a very conservative society, and there have been all sorts of attempts to block it. I would say that it's improved overall, and I would say that if women are interested, they can obtain it, but it's their decision to obtain it or not to obtain it. So it's improving, but it's still not where it needs to be. 51% of births are attended by skilled health workers, which means that 49 are not, and I'll get to that in a minute. And you can see here, this is the maternal mortality study that was done. This is a mistake, it's 2011, not 2015. So the maternal mortality ratio is 136 per 100,000. But as you can see, there are wide variations in the different regions of the country. In indigenous women, it can get, on average, it's 159, but in non-indigenous women, it's 70. So this is part of what goes on in the whole country. It's like two realities, indigenous women and non-indigenous women. And then also this is if you break it down by a geographic area. So this is the Northwest, the Western Highlands that we were talking about. And then you can see how low it goes and as the closer that you get to where more resources are available. As you can imagine, it's higher in young women under 14 years of age and over 35 years of age. And it's also higher in women of larger parity. If you look at the risk ratio in women over 5 years, it's like 10 times what it is in nulliparous women. The causes of maternal mortality are pretty much what you would expect in most populations. So the first cause is hemorrhage. The second cause is hypertension, and I put this in bold because Latin America has very high rates of hypertension in comparison to other regions of the world, and we're doing a study now to look at aspirin for reduction of hypertension, and we've found consistently that our hypertension rates are much higher than other areas. So that's something that we want to look at and that we want to analyze. So as things get better and as we get more resources, it turns out that maternal mortality law was approved in 2010. So the maternal mortality law states that women have to have access to health care. And if somebody blocks that access to health care, he or she can go to jail. So that includes all the way from the person who they saw in the pharmacy to the OBGYN who was at the hospital when they were seen. And it also includes the TVA if the TVA didn't refer her timely, the traditional birth attendant, or anybody who met her on the way. So this law was positive, and I believe there's not been another study done, so I can only believe that it's had a positive impact on maternal mortality. And it's also improved care inside the hospital, so now you can see blood banks, and you can see that the blood isn't under lock and key, which it used to be. And you can see that training programs take care of that, and that all the staff are paying attention to that. The bad thing is that it also makes things, instead of going to the intermediate ways of solving things, it sort of goes to the last way of solving things. So the C-section rate at the Chimaltenango where we work is now 50%. So 50% of all deliveries inside this hospital are resolved by C-sections. And in no hospital should it be higher than 20. 15 if it's not a referral hospital. So we're interested in looking at this further and then seeing what is happening here, because there have to be many factors related to it. And I think that the law is one of them. But it's sort of finding an intermediate way to solve things instead of going all the way to the end. So traditional birth attendants, and these are called comadronas in Guatemala, are a very large influencers and resolvers of maternal care in our country. in some communities, they attend up to 50% of deliveries or more. They're very well-respected members of the community in the sense that they often begin to work as traditional birth attendants because it came to them in a dream. And then in the dream, somebody told them that they needed to be a TBA. That was their calling. So they came to the authorities inside, the indigenous authorities inside the community. And they said, I believe that I need to be a traditional birth attendant. So they sort of get anointed to be a traditional birth attendant. And then they start working as traditional birth attendants, generally under the supervision of another traditional birth attendant who's older. So much more than just being providers of healthcare, there's sort of a godmother, religious type of figure in the community, and they are very well respected inside the community. So if you look at a lot of data inside the Ministry of Health and in other sources, you can see that many times women will go for prenatal care to the health center, but they'll also go to HERS. So it's very common to see both, that they go to both options. And with them, many women will choose to have deliveries in the home because they're cared by the TBAs. And a big part of why they choose to have deliveries in their home, we did a study a while back and they reported things such as, in my home, it's closed, it's dark, it's warm, I don't want to get cold. In the hospital, they make me take my clothes off. In the hospital, they make me take a cold shower. So it's a lot of cultural things that they don't find convenient in the hospital. So that's part of why they continue attending the deliveries with the TBAs. For a while, there has been tension because the Ministry of Health, to be honest, can't take care of the 50% of deliveries that the TBAs are attending. I mean, they don't have the capacity to. So the Ministry of Health hasn't been really strict about reinforcing that deliveries need to occur in the hospital because they don't have the capacity to attend all the deliveries in the hospital. But they've sort of reached a consensus in the sense that nulliparous women, so it's your first baby, you have to go to the hospital. Or if you have some risk, any risk like hypertension or any other, a previous hemorrhage or any other problem, they need to go to the hospital. If not, then you can stay at home, but she needs to refer you quickly. So the TBAs, and this is a pretty typical picture of a TBA, some are younger, but many are older. When we started in Chimaltenango, and Susan might remember this, but there were some that were 100 years old, and they were blind, so they needed to have an attendant with them as they were attending the deliveries. And so bit by bit, I think in other regions of the country, it's not quite there yet, but in Chimaltenango, the number has been going down and down and down, and more deliveries are happening in the hospital. I would assume that will be the tendency in most of the country as more of the country gets more resources. But this is a really important part of healthcare. The training that they get is like they have to come to meetings once a month by the Ministry of Health, and then the nurse gives them a training. And then some of them have supplies for safe birth kits, and then many don't. So it sort of depends. I also think that the law influenced them positively because it made them more accountable for what they're doing. So if a woman that they were caring for dies, she also has to go to a meeting where they analyze the whole delivery. So they're pretty quick. A lot of the times they will refer the woman, but the husband won't want to take her or somebody else won't want to take her. So if we talk about healthcare in Guatemala, 6% of the gross domestic product is spent on healthcare. But this is really important for you to know because 6% is not hugely low, but it turns out that the public spending is around 1%, and Social Security is another 1%. So 70% comes from private out-of-pocket expenses. So it's largely funded by out-of-pocket expenses. So healthcare depends on the personal availability of funds a lot of times. It's a fractioned and inefficient system because maybe sometimes somebody will go to the health center, then she'll go to the pharmacy, then she'll go to an NGO, and then she'll wind up at a private clinic, doctors. So it's very common to see people going through different levels of the health system. And no, there's no healthcare or Social Security for those that need it the most. So if you look at spending by Ministry of Health and by Social Security, and you compare it with the poverty rates and with the indicators, the worst poverty rates has the least spending. So it's sort of the other way. It should be the other way around. And in practical terms of where people report that they went to, which might be where they thought that their problem was solved, in this survey, I don't completely understand it, but it was a Ministry of Health report, so that's why I put it here, because I think it's the most official one. In that survey, 29% of people said that they didn't have a problem, so they were healthy, they didn't need care. But 47% said that they went to Ministry of Healthcare, which would be health centers or health posts. Then 10% said that they went to the private sector. 12% said that they went to Social Security. So more or less, that's where people get their care from. And the private insurance companies. So Social Security is sort of, I don't know what the comparison in the United States would be. It's like a semi-private public. If you have
public, but it's a bit of a, one of like Kaiser permanent.
It's public, but it's associated to you having a stable job. If you don't have a stable job, you can't have access to it. So this is not a private insurance. Private insurances are beginning to increase if you can pay for them, but they're still like under 5% overall. So I'll stop for a minute. Any comments or? No? Yes?
You mentioned about maternal mortality. Is there region-specific maternal mortality review committee? Because in this country, it's a huge issue. The president signed a maternal mortality reduction act to earmark $500 million per year for the next 5 years. So to that committee, they gave money to the committee in each state. So what happened in Guatemala?
So Guatemala is divided into 22 states, which we call departments, and each state has a funds for healthcare in that state, and then they do these committees once a month, and they go through all of the maternal mortalities that happened during that period. So now let's talk about research. Research in institutions, and I think this is common to a lot of Latin American countries, universities don't do a lot of research in Guatemala. They do some, but not a lot. And this is, I don't know why, but it's just the way that it's set up. So the ones that do it, and if you look at publications and funding and everything, San Carlos University, which is a public university, is at the top. Del Valle University also has a lot of it meets a lot of indicators for publication. And then you can see sort of a combination of Mariano Galvez, Rafael Andívar, and Francisco Marroquín that also do some research. And there's limited research in 12 other universities that occur in Guatemala. But if you think about universities in Guatemala, universities, what they do is train health professionals. Research is sort of an addendum to that. It's not the core of what they do. So where does research go on? Research institutions, and there are a lot of these. So INCAP, which I put in the first place because this is where I work. And then there are a lot of other research institutions where also research is going on. If you look at the national funding, in 2010, there were $19 million that were reported to be destined for research from both public and private investment. And there's a registration of close to 600 researchers that do this, out of which 100 and something are medical sciences. I'm sure that this is much higher, but this is just a registration of this. So there's this document that's called Areas and Priorities for Research for Health in Guatemala. So this was put forward by the largest institutions, the universities and the Ministry of Health. And so I just wanted to share this with you, but they classify as research priorities that's done for health systems, for health and disease, or for determinants of health. So this is sort of a classification of what is considered most important. And as you can see, it basically includes everything. So in health systems, human resources, financing, traditional medicine, public health, and then health and disease, nutrition, non-communicable diseases, maternal neonatal health, and then in determinants of health, poverty, food security, climate change, environmental health. So it covers a lot of different topics. So now I'm going to talk a little bit about our collaboration that we've done with the section of nutrition. So here's our staff. This is Michael, for those that haven't seen this. Nancy, Jamie, who's back there, and then this is Lester, who's our field coordinator in Chimaltenango, and we also, so you can't see it, but this is a picture of our whole staff. So we have 70 field staff and 12 professionals associated to our research collaboration there. We're based in the department of Chimaltenango, which is like the entrance to the Western Highlands. So it is 80% indigenous population. And from then on is that the indigenous population continues. But we're not that far in the Western Highlands. We're about an hour and a half away from the city, depending on traffic. So everything that we do is very closely related to the Ministry of Health. And for all of our protocols, we do get the Ministry of Health approvals. And for the implementation, we do them all in hand with the Ministry of Health. So we work with the health centers and health posts. And we also work very heavily in the community and with traditional birth attendants and community leaders. And because of the size of the protocols, because they're pretty large, we always need to keep all of these collaborations and all of these things in order to make it work, or else it would be impossible to get them off the ground. So most of what we've done has been part of the Global Network for Women and Children's Health Research. So the Global Network is funded by the National Institute of Child and Human Development, which also provides scientific oversight. They have 5-year cycles, so we're now starting the fourth? Yes. So we're now starting the 4th cycle. And it's a partnership dedicated to improving maternal and child health outcomes and to building research capacity in resource-poor settings by testing cost-effective, sustainable interventions that provide guidance for the practice of evidence-based medicine. So it's really a collaboration of both, and I would think that in all of the sites, this is really implemented in different ways. So the topics that we work, as the name states, is basically prevention of obstetric complications and improving infant growth and nutrition, and also reducing prematurity and complications from preterm delivery. There are 9 research sites. So a research site is a U.S. university that collaborates with an institution in another country. So you can see the other countries are Zambia, Kenya, the Democratic Republic of Congo, Pakistan, 2 in India, and now Bangladesh. So those are all the research sites. And then we also have as a data coordinator Stunting RTI International. So they're a data coordinating center. So all the protocols that we do go through all of these different sites and are implemented by most or all of the sites. So this is a list of the studies that we've done up to now. And so you can see that they've basically been in maternal and nutrition. And this is a participant in the field who asked us to take her picture because she wanted to have one and authorized us to use her picture. And then also of our data entry staff. All of the data entry is done in the Chimaltenango offices where we have our INCAP field offices. And then all of that goes into the database where it's analyzed. So I'm just going to go through the main studies that we've done so far because we're the only site that's more nutrition focused. All of the other sites are more obstetrical focused. So this was the first BITES trial, which was an RCT to test the impact of meat or cereal as complementary feeding. So it was implemented in Zambia, Guatemala, Pakistan, and the DRC. And what it consisted was one group of children getting amount of 30 to 45 grams of meat or fortified cereal to see if that would have an impact on their growth. And also we gave educational messages, which is part of the intervention. So the 3 messages were to improve the infant feeding practices, but that the mothers gave. And so we found at the end of the study that there was not a difference between the cereal consumption and the meat consumption on growth. However, we also found that the years of maternal education and maternal height were positively associated with linear growth velocity. So that was really important as in terms because maternal education keeps coming up in these things. I'll stop if Nancy wants to add something.
Oh, and it just keeps going down. I mean, they didn't differ and it just keep going down in their Z-scores.
Yeah.
That trajectory.
And this
Not much.
Yeah, and then this brings us to this other data, which we might continue.
No, go ahead.
You do it so nice.
Well, you'll notice at birth, they're short at birth, and they immediately drop down in their length for age. So, yeah, the length for age Z-score. And at 3 months, it's the lowest, and then it continues to drift downwards by 6 months. So it's starting very, very early.
So this has been really interesting because it's shown there was this conception that stunting goes on while the child is already living, but it actually, when the child is born, stunting is already going on, and it gets worse and worse. And then the other thing that was interesting also was that the weight, because the children were not growing, but they were gaining weight, the weight for length Z-score kept going up. So it was stunted babies, but the babies were getting heavier, which sort of mirrors what happens in the adults. So this was interesting because it was part of 2 students who were from here, actually, and they came down to Guatemala, and they spent a year in Guatemala, and they followed this cohort of infants, which is also really interesting because this isn't a cohort, it's not a transversal study, it's a longitudinal study, so they followed the same cohort of infants from birth up to 6 months of age. So that was a great collaboration to do here. And then this was from the Women First study, which I'll get to in a minute. So this was, without the intervention, this was just at baseline, looking at the stunting and the overweight and obesity in the participants in different sites. So we found the participating sites were the DRC, Guatemala, India, and Pakistan. So you can see here, the stunting in Guatemala was overwhelming in comparison to the other sites. It was 80% of the participants in Guatemala were stunted. And then you can see the other sites. But at the same time, if you look at the overweight, while in other sites there was much more underweight, in Guatemala there was practically no underweight participants, but overweight got to 60% of participants.
Can I ask a question?
Yes?
So is overweight being defined by BMI?
Yes.
Okay, because there are some studies now showing that in populations like Guatemala, BMI is probably, given the stunting, BMI is probably not the best measure, but really, mid-abdominal circumference, and so there's some work. I don't know how much you guys have analyzed that data that way.
We haven't looked at the circumference, but it's true. It sort of exaggerates the elevated. It elevates the BMI because of the short legs, basically. So it's true. But maybe it's only 60%. I mean, it's still hugely predominant. But absolutely, I think the BMI is, as a measure, is a little bit misleading.
And it's a proxy for actually.
Right.
Yeah, it's a proxy, not an actual. So after we did those studies and characterized the population, more evidence came out as to the importance of preconception maternal nutrition, because obviously the intervention that went on during infancy didn't have an impact. And there are surprisingly few studies focused on maternal nutrition preconceptually, but evidence has shown that when this happens early in pregnancy, it has a better impact than when it happens later in pregnancy. So based on that, Dr. Krebs and Dr. Hainbridge developed the protocol and obtained substantial funding for the Bill and Melinda Gates Foundation to do the Women First protocol. So what this protocol did was give a comprehensive nutritional intervention, which consisted of lipid nutrient supplements. So it's like a peanut butter that has micronutrients, which women had to eat every day. And in addition, if they were underweight, they also ate 300 calories of the same without the micronutrients. So it was both things. And what was different was the timing. So Arm 1 got it at least 3 months before becoming pregnant. Arm 2 got it at 12 weeks of pregnancy, and Arm 3 did not get it. They were the control. So what was looked at here, and the main outcome was neonatal length, because now it's so important that neonatal length is identified as a better outcome for future growth and well-being than neonatal weight. So we looked at neonatal length, and the conclusions of the study were that in low-resource populations, the benefits on fetal growth related to birth outcomes were derived from nutritional supplements commenced before conception or late in the first trimester. So those that started before conception and those that started late in the first trimester both had a positive impact compared to Arm 3, which did not get the intervention. So that's the overall study results. Now when you look at it by site, and you can see here, the graph is a little confusing to understand because it's better to be higher up, not higher down. So you can see in Arm 1 and in the different sites, but here, when you look at the risks, so if you compare Arm 1 versus Arm 3 and Arm 2 versus Arm 3, overall, there was a reduction in risk in Arm 1 versus Arm 3 and in Arm 2 versus Arm 3 across sites, but except in Guatemala. In Guatemala, for some reason, Arm 1 did not do better than Arm 3. So we're looking at that very much in detail. We're trying to figure out what factors could have been impacted by that, or if it was something related to the study, or evaluating why that happened. I don't know if you'd like to add on anything else. Okay. So our nutritional research priorities, we're looking into origins of stunting because it's obviously something that needs to be unlocked. Effective interventions, because many have failed in different settings, so we want to look at that. Their impact on neurocognitive development, because there's obviously a lot of information. And it's not a causal thing as much as an associated thing. And the thinking now related to stunting is that stunting in itself is not a problem, but it's a marker of other things that are happening. Diets in transition, which are a big issue especially in our site and also in the others. The double burden, as I mentioned, and then also IB genetics and what might be going on there. So those are some priorities for our future. And then in maternal and infant health, I'm going to switch right now. We have the MNH registry, which is a population-based pregnancy study in low and middle income countries. We've enrolled up to 60,000 women a year, out of which 13,000 have been in Guatemala, which is about 80%, which is about 90% of those that happen in the whole department of Chimaltenango. So we're not in the whole department, but where we are, we get close to 100% of pregnancies. The women get visited at early pregnancy, 48 hours after delivery, and 6 weeks postpartum. And what we ask is, we quantify the services and provide rates on stillbirth, neonatal, and maternal mortalities to inform other studies. So it has an observational component that allows us to observe what's going on, and it also serves as the control for other studies that we do. So it sort of serves that dual purpose. So this is data that we got from Guatemala, which followed babies from 2010 to 2013. And if you look at the perinatal mortality rate, you can see how much it went down. Now, this is not an experiment. This is just observational. But it turns out that as a natural experiment, deliveries were moving from the homes into the health services in the same time period. So you can see here, this is the proportion of facility births. So in 2010, 30% of the births were in the facilities. And in 2013, that number had gone up to 50%. And now it's it's over 60%. So you can see, we think that there's an association between an increase in facility births and the decrease in the perinatal mortality rates. This is another thing that we developed because neonatal deaths are difficult to classify the cause of death in low-income country settings because the deliveries are going on in the home or with the TBA, so it's very difficult to be able to figure out and to get an adequate diagnosis. So this is something that we did based on simple questions that we could get in the community. We developed an algorithm to try to classify what these causes of death were specifically. So this is the algorithm, so you can see major congenital anomaly, no, so then the diagnosis would be major congenital anomaly. Yes, then it goes through different questions, and then it classifies it into the most important causes of neonatal death. So based on that, we were able to make diagnosis of how these deaths were going on across the sites and in Guatemala. So here we were able to determine for all sites about 33% would have been due to infection, 30% would have been due to prematurity, and 21% would have been due to asphyxia using this algorithm. And when we compared it to other ways of classifying, it wasn't perfect, but it was adequate for what we sort of needed. I'd be interested in hearing Susan's input on this. And then for Guatemala specifically, we found a shift in the sense that we found a lot of deaths due to infection. And we found this is very interesting because we've also found in other places that infection seems to be a higher cause of death than in places. I don't know if in the Trifinia you've also found these infection to be a higher cause.
Yes, it's one of our highest. We don't have as many deaths, but from the ones that we have, about, I would say, 40% depend on infection.
Yeah, so there seems to be something there that we should be looking at. And then if you look at it by the day that the death happened, it's also generally consistent with which you would expect, which is that the asphyxia deaths would be earlier and then the infection deaths would be later. We also did a Zika and pregnancy study, and this wasn't a global network study per se, but we were able to get the funds and the ability to get the grant because we were doing the global network. And I know that there's also a large Zika study in Trifinio. So here this was part of the ZIP study that enrolled 10 sites in Latin America. So we enrolled, the whole study had 10,000 women. In Guatemala, we had 1,000 women. These were enrolled in Amatitlán and Mazatenango, which are on the southern part of the country. And we developed a laboratory capability to do both the IgM as well as the PCR in country. And we're now finishing the follow-up of the infants up to 1 year of age. The good news for the country is that there's no Zika. For the country. So some future directions for our MNH registry. that we don't have up to now. And here you can see the number of the cesarean section rates. So one is definitely looking at the causes of C-section and interventions to reduce prevalence. You can see that the problem isn't only in Guatemala. Other countries also have a similar problem. As they move to facility, they sort of have to develop capability to balance it out and not go straight to C-section. Because we are focused on nutrition, we're also interested in getting neonatal and infant length. As you probably know, getting infant length is quite complicated. It's more complicated than weight, because weight you just have to have the scale, but length you actually have to have the board, and getting that on a motorcycle, walking to people's homes isn't always easy. But it's a much more sensitive indicator and a much more important number than infant weight. So we're trying to move, and we're going to develop something to be able to incorporate this into our registry, at least in some sites or in some deliveries. And we are now gearing up to start a study to look at the effect of azithromycin for prevention of maternal and neonatal death and infections in deliveries in the Guatemala hospital. So those are sort of our more long-term, short-term collaborations. And I just wanted to finish, as we move forward and we become more and more aware of people in many sites being interested in collaborating and being interested in working in low and middle income countries. We think that this is definitely something good, and it's something that we need to talk about, and it's something that should be somehow have rules for collaboration and have rules for coordinating this. And I've always been critical that the Ministry of Health in Guatemala does absolutely no registry when any health personnel comes in. I mean, physicians can come in and they can do surgeries and they can do all sorts of things. The Ministry of Health doesn't register it, doesn't even check on it in any way. So I think that we need, as this increases and increases, we need to develop more rules or clear guidelines on how to do this. And this was published a short while ago, so it's just something that I wanted to bring it up because I think it's something that we need to talk about. So it's guidelines for responsible short-term global health activities and developing common principles. So for example, some of the principles are, and this was a review of many other guidelines that existed, so they sort of outlined what the most important ones are. So one was that there should be appropriate recruitment, preparation, and supervision of volunteers. The host partner, so there should be a host partner inside the country that defines a program, including the needs to be addressed and the role of the host community in directing and teaching the volunteers in order to make sure that it's really what the country needs. A third one is the sustainability and continuity of programs, because that's really a problem when somebody comes in and then they do something and then they leave and then the people don't quite know what's going to happen next. Obviously, respect for governance and legal and ethical standards, and I think that that's on our countries to define it. We have to improve in that sense. Regulate the evaluations of programs for impact, and of course the mutuality of learning and respect for local health professionals, which is a priority. And I think that to start off, I mean, when I've gone into these communities and when my family members or people that I know, the first thing that you learn is that you always take more out of it than what you think you leave behind. I mean, I think that that's anybody that's done it knows that from the start. So one important thing I think is recognizing the benefits for all for all those involved. And I think that also for when people come in, it's important to be aware of the history and the cultural and social realities. I mean, there are reasons why things are like they are. And so I just wanted to mention that because I think we should talk about it as a proposal. And I just wanted to close. This is our Mayan sacred book. It's called the Popol Vuh. So it says, they talked together, they thought and they pondered, they reached an accord, bringing together their words and their thoughts, and then they gave birth, hardening one another. So I hope we can all collaborate in that way. Thank you.
Thank you very much, Anna. I think we do have about 5 minutes for questions. So I'll start with Maya and then with Mary.
I just wondered about when you give the moms the supplement to eat and also the children, how do you ensure that they're actually compliant with eating peanut butter and then nutrients? Like, do you take their word for it, or do you do some kind of...
So this is sort of a problem common to many nutritional interventions. Yeah. So you can either just take the word for it, or you can go as far as going every day and visiting their houses and checking on it, but that requires a lot of resources. For this study, we collected the sachets. So they were visited once every 2 weeks, and at every visit they had to give us the packages. So if they ate it, they were empty, and if they didn't eat it, then they had to give it back to us like that. Other studies have asked 6 months later, how much did you eat? So it's sort of a range of different ways, and it recognizes. I mean, that's why we call it reported compliance. We can't. The way that we did it, we didn't witness it.
Great. So I'm Meredith. We've met at some point. Yeah, and my husband probably has their own senses.
Thank you.
So I really liked your slide just before this one, and I wanted to tie it into research. Your idea of the kind of guidelines for responsible short-term global health activities, and what your recommendations would be for defining what the priorities are for research. And coming from the perspective of a place like the University of Colorado, where people can look to really get a sense of what the priority research topics are.
Yeah. I think that is something that we have to do inside the country. I think that in order for it to be real, it's something that we have to do in the country. So I think that our country needs to get people together, define it, and then make it public. So I would think that until that happens, it's going to be difficult for people outside Guatemala to try to identify it because they don't exist. But I do want to share, I'm part of an ethics committee, and we've begun to get together and form like a national alliance of ethics committees. And it's also for research, and it's being done with the help of the WHO. So I'm hopeful, I'm going to propose that this be one of the priorities for when people want to do research. On the IRB that I am on, we do require that there be a Guatemalan institution involved with the research.
And perhaps to that effect, I mean, John, before I give the word to Nancy, John, in fact, to Trujillo side, you probably can describe your experience working with the community to help them learn how to ask those questions.
Yeah. So we did a study in 2013-14, I think, with students, just packed students down and did kind of a broad, deep, well, actually pretty broad and deep exploration of the community's sense of social and cultural understandings of health and wellness in the community. Partly just to get a broader sense of what that was, but also to help inform the Trujillo site in terms of what the community was thinking about. It was a remarkably successful study.
And then John, with his experience on IRBs, the other thing that helped us out was to put together a community advisory board that has been tremendously helpful for us in terms of, every time that there is a project, even though they are not an IRB, they do have to review our projects, and incredible, we have gotten from them research priorities that we were not thinking about, and they brought to us, and we basically just went for them just because they were interested in sort of looking at the school survey that we do now every 3 years is a base of that. So,
I wanted to follow up on your cause of death issues. First of all, thank you so much for what a powerful demonstration of what we can learn from sustained involvement in research and everything that you taught us. My question is about the difference between categorizing babies as preterm and birth restricted in an area where there's such a high prevalence of stunting and very poor methods of determining gestational age, especially with home deliveries.
So I think Nancy can respond to that. Better.
Well, so clearly it is an important issue and distinction, and this has kind of haunted the whole Women First study about how we define or how we determine gestational age. I think Guatemala has been, in particular Lester, who Anna cited as key colleagues there, has really advanced ultrasound capacity, and there's lots of ultrasound, and so that's obviously, I would say, is the gold standard. And so I guess I don't know what your rates of prematurity are, or how uncertain, what's the certainty around those. But that's just huge in terms of how you interpret, and you would think in a very stunted population, how much of that is intrauterine at birth, which is why we think the length at birth is really the thing to be looking at, not just weight. But I don't know if you want to say more about your capacity
from an OB perspective, the countries have gotten much more sophisticated in the last few years. There's now a supplement to the registry for ultrasound. So in Guatemala, like 70 to 80% of women get an ultrasound during pregnancy. It's not early, but it does happen. It's not the research level quality, but and then in other sites it's not as high, but it is over 50% in all sites except DRC. The registry now has like an not an algorithm, but a higher hierarchization, where a gestational age is assigned as a combination. So if you have ultrasound, if you have LMP, and then weight. So when we were in contact with you, I think we just used weight, like over and below the 5th percentile. But now that's been developed, so I think it's becoming more sophisticated. But that's as a whole. Guatemala, I think, has other challenges.
Our administration would have us believe that there's sort of a continuous stream of people coming up from Guatemala, and that must be impacting research and healthcare in some way. But what would you see as the predominance of families who are impacted by sending a father north or an eldest child north or whatever? And what can we do that would be helpful?
I think that's a great question. We were just commenting on that yesterday because it's obviously becoming more and more of an issue. In the area in Chimaltenango where we are, there is migration, but it's not huge. So you do hear that parents go away and then they come back, but it's not huge. I would guess that in Trifinio it's much larger. So I think maybe Edwin can respond to that question. What do you think would be?
Well, there are a couple of things, right? I mean, one is, yes, the migration. I mean, we have even areas of the community where men have disappeared, if you want to. There's a huge impact in the return of money because, one of the things that has happened is those funds that are sent from here to Guatemala really have impacted, standards of living of the population. We see all of these houses that suddenly get built that they will never be done under the normal living wage of Guatemalans down there. So there are some impacts in education because, of course, it's the perfect thing that, you send the mail to, gather money, send it to the women know how to invest it, right? Education and living. So basically, kids in many ways are being impacted by that. But there's a huge issue with family structure. And one of the ways to contain it really is, and I think that has been an impact, probably you have seen the same in Chimaltenango, but a great impact of our research has been that we also have been able to retain, especially women and men that actually want to continue their education. And these research projects really retain good talent and sort of provide an example of how we can achieve things locally rather than coming up to the States. So probably there's more conversation to that than what I'm saying. But Nancy.
Well, I was just going to also comment, we were kind of talking this morning again about the kind of discrepant results of the preconception trial in Guatemala. And, did they just not they didn't have the malnutrition that we thought they did, and that's probably not what's underlying the stunting completely. But then I was reminded as you're going through the history about what is the kind of level of stress in these communities and just how much is that impacting intrauterine growth and outcomes. And we don't have a good handle on that. It's hard to measure exactly, but there's this kind of underlying thing that maybe we've fixed some of the overt issues, but there's other things that we haven't measured.
And from a purely qualitative point of view, in different studies, so you hear about women's empowerment, and in different studies, what we keep seeing is that in our sites, in comparison to other sites, Guatemalan women are empowered. It's just that maybe they don't come out and do it very obviously, but I mean, they make decisions about what they want to do, when they want to participate, when they don't, what their kids are going to do. And there have actually been studies that when you do women's empowerment strategies and you come in and you do these type of interventions and then you see what happens, they actually cause problems because they change social structures. And then you come in and then you tell the women, oh, you have to tell your husband and you have to go out. So I think that Guatemalan women to some extent have found strategies to do what they want to, but it's probably not the same strategies that you would use in different. I think it's sort of passive, but they are doing it. So I think that there's also a lot of that, and I think that the migrant population also has an influence in that, to an extent that I've even heard of cases where, so the first thing that the money gets used for is to buy telephones so you can be communicated, and Guatemala has an excellent cell phone system. There are something like 19 million cell phone lines in Guatemala. So there are more cell phones than Guatemalans. But then the men ask the women to keep the cell phone open on WhatsApp or one of these things all day long so that they can see what the women are doing and where they're going to. So it's like extreme cases. So on the one hand, you see women that really are not going to do what they don't want to, but then on the other hand, you see like these extreme cases of trying to control them. So I would say it's complex. It's complex, but I think it just makes it all the more important to think about it carefully. Sandra?
So first of all, it's a magnificent presentation. And as I see all this stunting going on, I think it's time that you start doing some ancestry and genomics. And let me give you an example. We have, that Tomás, her husband, works at the unit of pediatric oncology. And we actually scaled up the supportive care very fast there. And we kept on seeing kids with leukemia that were dying and relapsing. And everybody said, oh, they're dying of infection and they were not getting the chemo appropriately. So we started doing the biology studies and actually found an ERG gene that the more indigenous ancestry you have, the more that gene is expressed. Mm-hmm. And that leads to very high risk acute lymphoblastic leukemia. That actually is a science paper. And then it was again found at UCSF. The first study was at St. Jude and the second one was at UCSF. And both found the same. The kids from Guatemala have this ERG and they're getting worse leukemias. So, and the second thing is that, I do retinoblastoma. We have higher incidence in retinoblastoma all in the highlands from Guatemala going into Honduras. It doesn't happen in Salvador, Nicaragua, which are, somewhat less. And we don't know why it's happening. But what we do know is that the kids with retinoblastoma, they're not attended early enough. And this happens in the indigenous populations. The ones that are metastatic to the mattress, things coming out of their faces, are indigenous. So it is partly cultural. But at the same time, even very, very poor people, they come in earlier. So I think it's a mixture of the cultural with the genetics. But what's even more that within that retinoblastoma study, they called me, oh, should we do some ancestry? And there were, like 120 tumors. 80% of the kids from UNA, which is the Childhood Cancer Center, are 80% Amerindian ancestry. Mm. So even though you think that ethnically they are, their race is more related to the Amerindian ancestry, which brings it to a very different composition. And unlike Mexico and Costa Rica, which killed all the Indians, I say indigenous people, Guatemala was really preserved because of their history. They conserved the mitas and they organized the beautiful textiles that they have. It has nothing to do with the Mayans, but that's how they knew where this person was supposed to be and come from in the 17th and 18th century. So with this stunting, you cannot find a reason why. I think you're going to have to look at the environment with the relationship, whatever genomics they have in their background. And we tried to do a couple of studies with leukemia and exposure to biomass smoke. And we wasn't funded because, of course, that's when all the funding was cut down and our school was 13 and wasn't funded. But nonetheless, there is more and more that is either going to be infectious or exposures, especially with all the pesticides, just going into non-communicable disorders. But, we see, and just to give you another, in the last 2 years, we've seen the stunting increase from 40% to 50% last year, which just means that this stress that you're talking about is getting worse at UNO. And we have that nutritional support that we provide from the beginning to all the malnourished kids, which is, I think, and we have to meet later and see how we can collaborate in this, because I know there is a lot going on. But I think you start to have to be looking at genetic things and epigenetic. We are. Yeah.
Thank you very much to everyone. I think Anna is around if you want to get more questions.
Thank you.